Hello, and good afternoon to everybody who's participating today in JBiz Innovation Healthcare 2020 virtual event. This is our second year that we've done this. Last year, several thousand people either were there in person or viewed it afterwards. And as you know, Jmore, which is Baltimore's leading Jewish family and lifestyle magazine, sponsors this. Jmore is distributed to about 12,000 families every month, and it has been a big success, and we're really thrilled to be sponsoring this event today. So we have several sponsors today, and I want to talk about our sponsors quickly, and then introduce our guests and our host who's running the event. First, let's talk about Nemphos Braue, one of our sponsors. They've been a sponsor for many of our activities. And some of you have heard before when we've done these events that they do lots and lots of work in the corporate law space along with other areas. I've been involved with them, I've worked with them, and they do a tremendous job. Very efficient as attorneys, getting transactions done. The second sponsor is the University of Maryland, Baltimore. We're thrilled to have them on board and to be they represent everything good about healthcare in the state of Maryland and many other activities of the University of Maryland at Baltimore. I've been more involved on the healthcare side. And then Sheppard Pratt. Everybody knows Sheppard Pratt, a leading national and international institution. And then, of course, the University of Maryland Medical Systems has been a sponsor before and for this event. And again, we forget how privileged we are in Baltimore to have the level of healthcare that we get between the University of Maryland and Sheppard Pratt and some of the other institutions in Baltimore. The level of healthcare, the quality of the healthcare we get is really phenomenal. Go out to some other places around the country and try to get the level of healthcare that we see in Baltimore. It's hard to recreate. Our guests today are George Nemphos, and George is here, and George is going to run the program and does a much better job than I do emceeing a program. George is a real asset and has been a huge, not only is he a great lawyer, but he's been a huge sponsor of charitable events and participant, everything from the Heart Ball to the Diabetes Association and other organizations, and is really an asset to Baltimore. From the University of Maryland, Baltimore, Bruce Jarrell, MD, the president of the University of Maryland, Baltimore, has joined us today. He's been the interim president during the pandemic and now is the president at University of Maryland, Baltimore. He has had numerous leadership roles at UMB, including provost, chief academic officer, research officer, senior vice president, executive. It's a long list. If I keep going, we're going to use up the whole show. Bruce, this is pretty impressive. I'm a lowly internist, so I'm very impressed. Bruce is also a surgeon and a highly regarded surgeon, and has been involved in lots of research and student education. From Sheppard Pratt, we have Dr. Todd Peters. Dr. Peters is the vice president and chief medical officer and the chief medical information. I'm always amazed by people that have so many jobs. I can barely do one, but also the chief medical information officer at Sheppard Pratt. He completed his residency and fellowship in childhood and adolescent psychiatry at Alpert Medical School at Brown University. He earned his medical degree from Penn State and has extensive training in ECT and childhood psychiatry. And he's double boarded in general psychiatry and child and adolescent psychiatry. He also serves as the consulting editor for child and adolescent psychiatric clinics of North America. All of this tells you is that he's really an expert. And then our third panelist today is from the University of Maryland Medical System, Andrea Levine. She's the assistant professor of medicine, Division of Pulmonary and Critical Medicine at the University of Maryland School of Medicine, program director for Critical Care Medicine Fellowship, a critical care physician, which means she's been in the middle of everything going on with COVID, and research efforts in post-ICU syndrome and post-ICU survivors. Dr. Levine's training, including medical school at the University of Maryland, fellowship at the University of Pittsburgh. And here's the part that gets me. I barely got boarded in medicine. She's boarded in medicine, critical care medicine, and pulmonary medicine. I'm very impressed. And I'm going to turn this over to George, who's going to make some sense out of all of this. But thank you all for being here today. We truly appreciate it.
Thank you, Scott.
George, you're up. I think we lost George.
No, I'm here.
There you are.
I accidentally got thrown back on mute, so we're all good.
No problem.
No, but I was saying, thank you, Scott, for the introduction. On behalf of Nemphos Braue, we're thrilled to be a part of this series with JBiz. You know, it's been terrific being a partner with JBiz in a variety of ways. And, you know, I can't say enough positive things about Scott and Lauren and John and the team there and all that they've done for not only these events, but also for, you know, the area. They've done a great job bringing issues to the forefront, giving us some amazing editorial pieces on businesses, you know, current events, and there's plenty of them these days. And, you know, we're really excited to be here and be a part of this. Scott said Nemphos Braue is a corporate boutique law firm. We really try to be more than just a law firm. We tried to make it so that way our work is utilized over and over on behalf of our clients. So that way it's not merely an expense, it's an accelerator, if you will, of business. So that's why we're big supporters and sponsors of JBiz entrepreneur events, you know, because we believe in the community and we believe in what's being done. And we're especially thrilled today to be a part of this event and have the opportunity to talk with these three distinguished doctors in front of us. To this evening, we're going to start with Dr. Jarrell. Dr. Jarrell, as Scott said, is the president of University of Maryland, Baltimore. He was the guiding hand in the university's efforts to cope with the COVID-19 pandemic. And, you know, he's definitely had his hands full every day. I'm one of those people who looks at the stats and keeps an eye on it. So, Dr. Jarrell, I mean, I want to give you the floor for a few moments here to tell us a little bit more about what you're doing and what the university is doing in this area before we dive into some questions.
Good afternoon, George, and thank you for having me here. My partner, my academic partner of many years, Jay Perman, always spoke very highly of the organization that you have, and I was quite used to seeing your periodicals. So it's nice to be on here with you. I took over for Jay officially the second week in January. March 14th is the date that stands out in my mind, which is when we went remote at UMB. And I remember the day very well because I started receiving text messages, believe it or not, from Italy, and started seeing what was happening in Italy and saying, geez, you suppose this is for real? Is this really happening? And after digging into it, excuse me, it became quite clear that was what was happening. And so we really moved to remote activities very quickly, including our clinical rotations. I did that with a heavy heart because what kind of physician or nurse or pharmacist or whatever are you if you don't take care of patients? So we moved very promptly to that. We have moved back to having clinical rotations, and I would say that that's going pretty well. We have also moved back to doing basic research at what we call a 50% capacity. So the density is low, but the intensity of the research is back up to where it belongs. And we've also begun to do a broader amount of clinical research. Now, having said that, we never stopped doing certain kinds of clinical research and basic research. We certainly did COVID-related research. We started clinical research in COVID-related things. And of course, we continued the kinds of clinical research that are critical to people's survival, people in cancer trials, heart disease trials, et cetera. So we're moving along pretty well, I would say. And pretty much all of our activities are the way they were before COVID, with the exception of our didactic programs. We're pretty much all remote for the didactic parts of our schooling. and we still have 5,000 people a day who telework. So when you walk around the campus, you can hear an echo in some places. But people are doing really, really well. And I think the fatigue is starting to set in terms of all the precautions and not seeing your friends personally. But I guess we're in this for at least a few more months, probably more than a few more months, the way it's looking right now. But we've been doing well, and I think the university is healthy, and people have been extremely cooperative during these very difficult times. So, George, that's our current state of the art.
No, and I appreciate that, and please, I know everybody on today's Zoom commends everybody involved from the healthcare world. You are heroes in all of this, and it's important to remember that, and it's important to remember that you heroes have families of your own, so you're giving up a lot, and we thank you for it. But it's interesting when you made the comment of we're in this for a few more months, if not longer, likely longer. It does lead me to my first question, I think, and it's probably a broad question, but it's one that I know is a hot topic out there, and that is really, why are vaccines important, and what should we be expecting?
Well, you all know that in the first or second year of medical school, we all learn about Edward Jenner and cowpox and smallpox, and how learning how to vaccinate people from the cowpox controlled the smallpox. And it was the first example. And in fact, Mike Levine, who ran our Center for Vaccine Development, took great pride in participating in the eradication of smallpox from the world. At least that's the prevailing theory here. And so I think it's an example of how we eliminated a disease. We haven't eliminated things like influenza. As you know, those viruses have a way of evolving over time. And so we can control it, we can't eliminate it. And I hope that COVID falls at least into the category of we can control it with these vaccines. There are a number of really good candidates out there right now. Some of them very novel methods to create a vaccine. And University of Maryland has been very involved with that. So do I think it's critical? Yes. And I don't know how many of you on the show remember that there was a time when you got measles, they nailed in my case, a green sign on the door that says quarantine, do not come in, and I couldn't go out. And the days of that are pretty much gone now. The same with mumps, the same with chickenpox, the same with a lot of diseases that had some pretty serious sequelae. So I think vaccination is a really good way to go if the virus, in fact, allows itself to immunize us from the vaccine. So a critical piece in the treatment of this prevention of this disease.
It leads to another kind of spotlight on the issue, which I think we all hear a little bit about in the news. There's a lot of families that are anti-vaccine or during this COVID period struggling to stay on schedule with vaccines for their children. I mean, what do you say to those families? I mean, how do we press upon them that, vaccines are, staying on schedule really does matter with the way in which vaccines are done?
It does. And so when you think about everybody being focused on COVID, other diseases are still around, particularly the childhood diseases. And kids aren't going to school, aren't going to see their doctors, they're putting things off. They're not getting those vaccinations. Dr. Jim Campbell, who is in our Center for Vaccine Development, really made an appeal to a number of people to make vaccination clinics more available. And so UMB has stood up several of those clinics in West Baltimore. And you may also have seen, actually this morning in the Sun paper, there was an op-ed from our School of Pharmacy pointing out that, hey guys, you can get vaccinations at pharmacies as well. And as you many know, you can get them at your Safeway and CVS and a lot of different places. So keeping up with the childhood vaccinations is a critical piece, and it's so easily overlooked. I'm worried about COVID. I'm not going to school. Well, I don't really need these other vaccines. The one silver lining, I think, in this is there was an interesting report that came out about 2 weeks ago that talked about influenza, particularly in countries in the southern hemisphere of the world. And what they were finding was, with all of the precautions that we're using with protective equipment, as well as staying in our house and social distancing, that influenza typically peaks around now in those countries. And what they saw was a very flat curve. So at least there's a hope that influenza won't hit us as hard as it does in some years. But we'll see about that. But that was very good news to see.
Let me jump in. George, let me jump in for 1 second. I want to point out, and we get about 2,000 to 3,000 people that watch this. We do a bunch of shows, not just on business. So a couple thousand people will see this on Facebook and YouTube and all kinds of places. And a pretty broad, this will have more of a business audience, but a broad audience as well. I wanted to point out that you can actually get your flu vaccines as a drive-by now.
Yes.
I did not get out of my car. I pulled up the Wegmans, the pharmacist came out, shot my arm with the vaccine, and off I went. It was pretty amazing.
It's remarkable, Scott, the way we've changed the practice of medicine. And that's just yet another example. Drive-by nasal swabbing, drive-by influenza vaccine. You would have never thought that would happen a year ago.
Yeah, and some of this stuff may still be here 10 years from now with the way we've made changes.
Yes, I agree.
Very good. George, I'll hand it back to you. I apologize for
No, anytime, Scott, anytime.
Scott, the one thing I'm sure of is that there won't be remote surgery.
Right. Well, I was thinking of a home surgical kit. What do you think?
Well,
give me
good luck,
direction.
baby.
I saw a movie like that once, actually.
That's called the game Operation, Scott.
Right. I wasn't meant to be a surgeon. I have shaky hands. It's not good. It's not good. Very good. And George, by the way, I got to point this out. Is that a tux you're wearing?
No.
Oh, I thought there was a tux.
No, it's very fun. It's actually a lining insert on this thing. The temperature in my building is so up and down. Half the day I'm wearing a sweater. The other half the day I feel like I need a t-shirt. It's been fun. We're at that time of year in Maryland.
Yeah.
But Dr. Jarrell, we have a question from somebody watching today. How do you feel? What do you think? How about the job that we're doing in Maryland and in the area, controlling COVID as it relates to pretty much the rest of the East Coast, let's say?
I'm very impressed with what's been happening. I think the governor has made some excellent decisions. One of the best things that I think he did was to get a group of physicians and experts in epidemiology and vaccinology and emergency medicine around him and asked for their advice frequently and followed their advice. So I think we have been wonderful. It could be a lot worse right now, George. And I'm still worried about Maryland, but I think we've had excellent leadership, and I certainly hope that continues.
That's good insight. And thinking about the leadership in the state of Maryland, I know that UMB has been pretty involved in things. So what is UMB's involvement right now? I think it'd be good to know what it's doing with regard to development and with a COVID-19 vaccination trials, things like that.
Well, there's maybe 2 or 3 things that I would mention, and Andrea may mention some things as well. I would start with Dr. Matt Freeman, who's a faculty member in the School of Medicine, a microbiologist, and he's been working with coronaviruses for over 10 years. There aren't many of these kind of labs in the country, and he has a pretty sophisticated approach to this. And I know he's interacted with a number of companies and others in the state who are interested in things that are coming out of his lab. So first of all, there is a very basic science effort here, which I think we're all proud of. But really what's come to the fore is our Center for Vaccine Development. Mike Levine started that over 40 years ago. It's a premier vaccinology program. Right now, I know that we're involved in 3 trials. We finished a first phase of a Pfizer trial, a different Pfizer. We're now just finishing enrollment for the Moderna trial, which will have 30,000 nationwide enrolled in it. And I know Novavax is next on our list. The Center for Vaccine Development has a spectacular reputation of being able to stand up vaccination trials, clinical trials, almost overnight, but yet to do it in a highly efficient manner such that all the FDA hurdles and all the other approvals get taken care of properly. It's even internationally known because of its ability to do these even larger trials. So right now we'll have several hundred or more in the Moderna trial, but talk about several 10,000 in Africa, looking at broader clinical trials for vaccines. So it's really a robust capability here, and Maryland has a lot to be proud of to have a program like that here. And in fact, several of the leaders in it are playing major roles with the governor, playing major roles on the Operation Warp Speed advice, and now major roles on how the vaccines will be meted out to people who gets the priority on them first, those kinds of things. So it's nice to be in that position.
And there's been a lot in the press as of late about how the vaccine, when it's developed. I don't want to say if, when because we all expect and would expect that we will have something at some point. But there's been a lot in the press about how it will be rolled out. And, you know, what can you comment about that? I know that, you know, everybody's got an opinion, but it sounds like that the approach that's being taken really is being done to take care of our most at-risk individuals and those that are going to take care of them first.
That's what I've been seeing based upon need. And you can think of a number of categories that fall under that. The one category I would underscore is the underserved communities in Baltimore and the state of Maryland. And one of the things I was particularly proud of in the Center for Vaccine Moderna trial was that there was a major effort to involve the Hispanic community in Prince George's County. And we've also targeted including African Americans in the trial, because for people to have trust that this vaccine is going to work, they need to see that people that are similar to them have been involved in the clinical research. I think that's an exceedingly important goal to try to achieve. So that's been a major emphasis here.
So making sure that with the sampling and the testing that's being done is really in the broader community, something that, you know, we can show, you know, that it's been tested, if you will, as much as possible.
Well, not just efficacy, but how about safety too?
Yeah.
Okay, you'd like to know that somebody like me got the vaccine and they did fine. You'd also like to know that somebody like me got the vaccine and I was protected against the COVID virus. So yeah, those are really important milestones to hit in a clinical trial. Children too, of course, eventually.
Of course, no, absolutely. So I guess I would question, my last question, if you will, for you, and you can feel free to pass, would be if we start heading into the winter and it starts to look like a spike, what would be your advice? I think something you said earlier is really I would say probably is resonating with the general public, especially in Maryland, which is people are getting a little fried out on being, you know, wearing all the PPE and
Right.
scrubbing their hands every 5 minutes. And I think the idea of staying at home, again, really feels a little detrimental to the psychosis of our great state. So what would you, as we're heading into that, what would be your main tips to try to avoid that? Try to avoid, or, you know, what we can do?
Well, first of all, I'm sure Dr. Levine will be talking about how difficult that is in the hospital setting. But what I would say is this concept of COVID fatigue is a real thing. People are tired of following all these rules. And, you know, it's like if you follow them 95% of the time, that's better than 50%, but 95% still leaves you exposed for that remaining time. And when people go on breaks or have lunch or things like that, that's when they let their guard down. I think, George, I would leave you kind of with three things. First of all, I think the UMMC and the hospital system, is showing extremely good data to say if you follow the precautions and you follow them religiously, you will protect the workforce. And so the UMS workforce has been very protected and it's not just PPE. PPE is important, but your practices of hand washing and mask wearing and face protection, et cetera, social distancing, that stuff's for real. And I think when you talk about the influenza in the Southern Hemisphere, it's because people were using these methodologies and they actually really, really work. Now, that doesn't solve our problem of being at home, et cetera, but it protects you. And you know what? I want to be protected and I want to protect those around me. So that's important. The last thing I would leave you with is clinical trials are important. And I don't mind telling you I'm in the Moderna trial. I got my booster shot. I'm now I'm 2 weeks out from my second shot. I don't know whether I got the placebo or the real thing, but it's important for people of different ages, of different races, of different backgrounds to participate in this. And so I would urge everybody listening to keep your ear out for this kind of opportunity, because we need people to participate in these trials from wherever you're coming. And so to me, that's important. This will be my 5th vaccine trial.
Cool.
And so when you remember the swine flu and the avian flu and H1N1 and H1N9 and that, so this is my 5th one and I'm proud of it, and it hadn't hurt me yet, and it's probably helped me. So I would leave you with that parting idea.
That's amazing. And again, thank you. And I want to say, I completely agree with you. I'm laughing as you talk because everybody in my office has multiple bottles of this on their desk. This never leaves my side.
Yeah.
So I mean, you're right.
Keep doing it.
Absolutely. And I will say, the only thing I'll say in response to all of it is, if those of us that have school-age children, woof.
Yeah.
How would somebody volunteer for a trial?
There's the Center for Vaccine Development has a website, and you sign up for it ahead of time. They do look for certain categories, healthcare providers. They look for people over certain ages. I won't go into that. They look for racial mix in the group. The one comment I would make is that they have been overwhelmed by people wanting to participate in these trials. That's a really, really good sign. And I hope it carries over with less life-threatening viruses 5 and 10 years from now. But you sign up on their website, Scott.
Thank you, Dr. Jarrell. Thank you.
No, thank you, Dr. Jarrell. Thank you for coming on tonight. And, thank you for all your efforts and your team's efforts, and for taking part in the trial.
Yeah, well, it's my pleasure being here. Thank you for inviting me.
No, thank you very much. So next to join us this evening is Dr. Todd Peters. Dr. Peters is the Vice President, Chief Medical Officer and Chief Medical Information Officer at Sheppard Pratt. We're very lucky to have Todd. Dr. Peters is also served as the consulting editor for Child and Adolescent Psychiatric Clinics of North America. So at this time, I'd like to get Dr. Peters up and start grilling him. Todd, can you hear me? Todd, need you to open your mic.
Yep, sorry. Hey, how's it going? Sorry about that. I was waiting to be given the keys to open my mic. So very nice to meet you both, and thank you for having me.
No, appreciate it so much. And I think Dr. Jarrell and Dr. Rifkin, made a pretty interesting comment about how medicine is changing. A year ago, we never would have thought about, drive-through shots and things like that. And, our smart devices are becoming so important. So first question, I guess, an overarching one, and it's hard to think of it this way, but is there a silver lining to COVID-19 in terms of how we've been delivering care and what it's forced us to do as a society?
Yeah, there definitely are, and we've really at Sheppard, and I know, talking to colleagues across the country, have definitely really been trying to take stock of these silver linings. I think the biggest one for us in the mental health field, telehealth is actually really a wonderful tool to be able to use in medicine, but especially in behavioral health care, because I know we joked a little bit earlier about not doing telesurgery, but a lot of what I do as a psychiatrist can actually be done through a Zoom meeting. Now, that doesn't obviously take away from the direct interaction, which is still of vital importance. Again, in my toolkit, me as a provider is the number one tool that I have when I'm working with children and families and with patients. But we at Sheppard have actually been doing telehealth for 2 decades. This is not a new thing to us. But during COVID-19 and during the pandemic, our scale of growth has really grown so exponentially. What it really has allowed us to do is reach out to larger audiences than we ever have before. Previously, there's a lot of regulations in the state, but also nationally, that really sanctioned how the telehealth needed to occur. It needed to occur from one site of origin in a patient clinic to another site of origin in a patient clinic, and have monitors of this size and other sorts of things. And again, I know why a lot of that's in place, but I will say to you that with this pandemic, there was a lot of loosening of those regulations, and it allowed a lot more people to be able to access care in ways that they never have before. So for us, we've been able to reach out into the broader community, extending group sessions for substance use and mental health to the folks that maybe would have never had access to care before. Our crisis walk-in services, which has been really a pride of ours at Sheppard, which is really creating, we have up to about 12 hours or so a day that we have a clinic here at our Towson location that we allow walk-in visitors to come in an unscheduled way to be able to be seen and assessed. That's been going on for years. In April, not only have we been able to keep our doors open for the in-person clinic, but we actually opened up a virtual crisis walk-in services. And that we were really committed to that because, again, our job as a behavioral health provider, we wanted to be in this COVID fight. We are working with, COVID positive patients in our inpatient setting if people do convert. And so we're definitely not, we definitely are part of this COVID journey, but our main goal is to work to do as much as we can to decompress the medical emergency rooms and to keep folks that don't need to be exposed to COVID, home, and being able to be able to stay at home and isolate, but also at the same time, those that need mental health treatment, being able to get that without taxing our medical systems. And so this allowed us to provide direct care to individuals in their home and meet them at a time of need and in crisis, and be able to actually refer them to outpatient services, more acute outpatient services, or even inpatient services, and really avoid having to go unnecessarily to a psychiatric ED. My hope would be that when we're not in the pandemic, this type of care is able to continue, because again, I would love nothing more than to decompress medical EDs in the future and non-pandemic times too, because I'm looking around for nods from my brethren, but I know that there a lot of folks would love us to be able to continue this moving forward, because we just know that unfortunately patients that are in psychiatric need sometimes languish for long periods of time in emergency rooms, again, to nobody's fault, but there's really sometimes just getting connection from point A to point B can take a while. But just to give you an idea of the scale, we have had well over 200,000 virtual visits that have happened since this pandemic. Our virtual crisis walk-in services alone has had thousands of visits in just even a couple of months. And so again, it's really been quite phenomenal what we've been able to do in a very short period of time.
No, it's very commendable. I mean, you hear a lot about COVID anxiety and how it causes things to start to bubble up that may have already been there, but being isolated from family, friends, worried about being infected and all that, it can intensify. So, a lot of the places where you start to see that, I would think, is in the employment situation. as myself as owning a business, and anybody else on this owning a business, the process of telling your employees that you need to telework to bringing them back, you know, you can see things. I think you're probably one of the groups that see it more readily and more quickly. What can we as employers, as we start to see this start to happen, what can we do as an employer to try to help them seek the care they need, or what can we do to get them access to the types of things that you're talking about?
You know, early in this journey, I will say this was one of the things. You know, us working in the behavioral health and mental health field are not immune to this as well. We had to first and foremost balance the two of how do we extend services for other employers, but also take care of our own. We have 5,000 employees here at Sheppard Pratt across 387 sites of service. It was our staff were facing the same challenges that all of us are. What do I do with my kids? How do I keep people safe and anxious about their own life and livelihood? And so one of the things that we did initially was extend free therapy services to our own employees through different channels, not just seeing their colleagues, but created that infrastructure there. And that really helped us. You know, this was something that we were already very focused on before, because really the data shows that mental health treatment is an important investment for employers. More than a quarter of US employees want their employer to provide support for mental health treatment. And 4 out of 10 Americans indicated, you know, that the pandemic is really, you know, impacting their mental health. So it is a bigger issue than ever before. And so one of the ways that we've kind of dove into this even more than before is really to launch a new direct-to-employer mental health program called Sheppard Pratt Direct. So this is a tailored partnership that is customized so that way employees can get services that they need without really any unnecessary frills. And this way we're able to kind of really figure out what does that employer need at that time. So one of the principles that we brought in is obviously opening up a dialogue and educating on these different things that can impact employers, and talking about things like parenting through COVID and work-life balance while working from home, and couple and family communication best practices, coping with grief, especially those that maybe not even just lost somebody to COVID, but just maybe had somebody pass away, not from COVID, but they weren't able to grieve and get together in ways that they had before because of this pandemic, and dealing with financial stress. And so what we work with employers on, and this isn't just, you know, just what we're doing, but I think what really should be done is being able to normalize the idea that anxiety is a feeling that we all feel at any given time and is quite heightened now. One of the things that we really work on is mental health first aid training, which is teaching folks the early warning signs of mental health issues. So it's kind of first aid training, not to just know how to do CPR, other sorts of things. This is they're teaching folks kind of almost like the CPR principles or BLS principles toward mental health. So being able to understand what are the signs and symptoms of anxiety or depression, and being able to start that dialogue. Doesn't mean you have to finish that dialogue, but be able to know how to help and to triage situations and be able to recommend that folks get help when they need it. And I think that understanding of that, coupled with accessibility to the services when one is in need, is a really important duality during this time.
No, I appreciate that. We actually have a question for somebody, and you know, the question is around, you know, something I alluded to earlier, which is, are you or your colleagues seeing any notable effect from COVID-19 on high school or grade school kids right now? And if you are starting to see it, how should we be dealing with that?
Yeah. So as a parent of 2 children myself, I do fall into that category of folks trying to figure it out with virtual school and other sorts of things. It's a challenge. My son would be the first probably to say that he likes school for the socialization, and you know the schooling happens while he's there, and not having that aspect or having it be different is very tough. And I've heard from dozens and dozens, multiple families that said, you know, my kid has always just been a wonderful student, but really just can't hack it at this virtual care, and it's tough. So as you talked about before, I guess I would consider myself an IT expert as being a chief medical information officer here, along with being CMO. But I find it hard to kind of balance the first go to this for, trying to organize it even for my child. And as an adult with a pretty good functioning frontal lobe that has pretty good executive functioning, I find it even hard. And so it has been very taxing on young kids, especially those that this is their first school experience, for the kindergartners to the other grade students, grade schoolers that don't have that, and also to high schoolers that I think are, kind of, lamenting and really struggling with that, almost that grief and loss of, this is my senior year, it was supposed to be different. And I know we're all facing that, we're all finding that happening, but I will say that it definitely has been, impacting a lot of those age groups, I would say, even more than some other groups.
And with that in mind, when we get it through this, I mean, is there any concern amongst you and your colleagues that we're developing a bunch of kids or teens that are going to have some social skill issues or some lingering effects long term, and how should we as parents be thinking through that?
Yeah, I will say that these I hate to be the bearer of bad news, but I would say that that the pandemic is going to be long lasting in the ripple effects with it. And so I will say that this is not one of those things that we're going to just say, whew, glad that's over with, and almost consider it like graduation, where we throw our masks in the air and just kind of go on to the next part of our journey. There's definitely going to be after effects from this, and I think this is really the important time to incorporate into the family narrative talk around the idea around anxiety or sadness, and normalizing those as feelings, and starting a dialogue of making it a daily part of the check-in, to check in with their kids about how they're doing. I would like to say that as a child and adolescent psychiatrist, I'm an okay parent, but I'm definitely not always great. But I will say one of the things that when we're firing on all cylinders and things are going well, at the dinner table, we'll kind of do something like roses and thorns, if you will. This is an example of it, where you can really say, what were the parts of your day that went really well? What were the parts that didn't go so well? What worried you the most about what happened today? What were you most angry about? And normalizing that discussion and making it part of that daily routine with my kids makes it much easier then for them to talk about the big stuff. Plus, for me as a parent, it helps me to know, like, that's different than it was before. And it doesn't mean that I just go into psychiatry mode and say, well, tell me more about that, and turn it into a therapy session. But it helps by normalizing the idea that there are good parts of the day and not so good parts of the day, and worries and fears, and doing that myself. So part of that is also, as a parent, modeling that for my child as well, to also say, this is a tough part of my day too. So do I get into the nitty gritty about patient interactions I had? Of course not. But at the same time, I'm able to talk with them about difficulties that I had during the day, and the struggles that I'm having, even dealing with this whole pandemic.
Understood. So I'd like to leave you with one big question. So where do you see the next big innovation for healthcare delivery? You've been in the middle of it. You're on the front line delivering it in new and unique ways that everybody is, only could dream about, 20 years ago, that this would end up being everything to us and potentially life-saving. Where do you think we're headed? What do you think we're going to come out with this?
So I think the big thing, back to the silver linings, I think we really just need to, what I'm most worried about for us is that we don't do as much as we can to learn from this whole experience, and to adjust policies that allow us to continue some of these good things that we've done during this time. And so my worry that I have is that if we just lapse back to the way that the policies were written before, we'll lose a lot of the headway that we've made. And so my hope from the innovation side of things is that we continue to really explore those regulations that may prohibit us from being able to do care that makes sense for individuals before, and also the innovation then to take it a step further and to think about payment models and other sorts of ways, so that way organizations like myself can stay whole, but at the same time, we are able to actually decrease the cost of healthcare moving forward, and be able to do I would love to see us do even more than we have before from a population health control to make sure that folks have the ability to check in more regularly and exchange data and use other sorts of rating scales and other sorts of things in between visits, that we get away from just the I come to see my doctor when I'm sick or for my healthcare checkup, but there's ways for my provider to communicate with me on a regular basis throughout. And we have some of that already, but the idea of sending patient-reported outcomes to a provider and me as a provider being able to say, George was seeming better than he was 3 months ago when we last did this. Maybe we should reach out and talk with him. We're already doing. We've done that for years actually at Sheppard Pratt with a lot of the innovative models that we have. I think for us as a country and as a healthcare system to take that next step is we need to do some of these other things that we have been able to do in a non-fee-for-service world and extend that more broadly and incorporate the technology and the things that we've learned to help us with that.
Wow. Well, Dr. Peters, I appreciate you coming on, giving us quite a bit of food for thought. And, and it's easy to forget, if you will, as a layman, how important, and mental health is during this time period. And being the father of two, a daughter that had her college graduation canceled during the middle of this and a son starting high school, I understand that checking in and watching over them and making sure that things get moving along and that there's some semblance of what we would deem to be normalcy during these milestone events that are occurring to this time period. And,
George, can I then ask a little question?
Sure, please.
So, Dr. Peters, folks were scarred by the Great Depression and affected their whole lives. Are the children of this generation, and I'm not talking about the college students, but the elementary school students, the middle school students, are they going to be scarred by this? This is really a life-changing event. Do they spend their life in fear?
That's a tough question. What I will say is, what I'm proud of, we still have some work to do, but I do think that there is much better understanding of mental health issues, and there's way more talk about it in the media and more broadly. I think in the Great Depression, I'm going to generalize a little bit, but I think a lot of it was we talked about the soldier's heart back then, and that was really PTSD. But we talked about this like a soldier's heart, like this was part of like the bravado of being a soldier and fighting in a war, and this is just one of the aftermath of that. Instead of as much just being able to to call it what it truly was, which was really dealing with post-traumatic stress and helping people through that. So instead of just something that was thought of as being a given, we've now flipped the script to really say, mental health issues are treatable. Early intervention is very important. Getting people the help that they need before something becomes a disorder is really important. So my hope is that by starting these dialogues and having much more accessible mental health treatment to all, that this will hopefully help to stave off the same effects that we saw maybe from our ancestors. At the same time, though, it also means that we're going to need to be doing a lot more than even what we're doing still. And we already have a shortage even of child and adolescent psychiatrists and mental health providers. So we're going to need more people joining in on that and really helping to be kind of at the ready, because I think right now that a lot of the first responders really are the folks that are gearing up in the PPE every day and fighting on the front lines. But the after effects are really going to be these other first responders that are going to continue to be first responders in this mental health fight moving forward.
Great. Thank you. Thank you.
Well, thank you, Dr. Peters, for that, and the terrific work you're doing. I think it's going to be practices like yours and individuals like you that are going to really help keep pushing the envelope in alternative technology and medical delivery to patients across a wide variety. Telemedicine is just amazing, and I do, while it's probably not the greatest way of saying it, I do believe perhaps that it is the silver lining in all this, that it's forced us as a country and as a society to push forward in trying to find alternative ways to deliver medical care to those that most need it. So thank you very much for your time and effort.
Well, thank you. And as Bruce said, I'm really proud of everyone here at Sheppard Pratt. I'm proud of our community and our state's response, and happy to be a part of this tonight. So thank you very much.
No, thank you for taking the time. Thank you. So next, I'm going to ask Dr. Levine to step up to the plate and give us her thoughts. As Dr. Rifkin most eloquently put, Dr. Levine has got more certifications and accolades than I can list off. But it's worthy to note that Dr. Levine did attend medical school and completed a residency in internal medicine at our own University of Maryland School of Medicine. And then unfortunately did go off for a fellowship at University of Pittsburgh Medical Center and was, obviously forced to watch the Steelers on Sundays. I could only imagine the harassment you probably took a little bit if you were cheering on behalf of a Baltimore sports team during that process. But no, thank you very much for joining us this evening. We appreciate your time and all your efforts and everything you've done during these difficult times.
Thank you for having me here. I appreciate it.
So I guess I want to lead it off with, tell us about your experience caring for COVID patients.
Yeah. So I've actually spent between 4 and 6 weeks caring for COVID-19 patients in our medical intensive care unit here at University of Maryland in Baltimore, and countless number of weeks caring for patients in my outpatient clinic as well that are COVID-19 survivors. I was thinking when Dr. Jarrell was mentioning the text he was getting from Italy that I actually took care of the very first patient who we had in our hospital who had COVID-19. And so I've really been kind of involved in this from the very beginning. I've watched our hospital open up the biocontainment unit, which we initially had built and used for Ebola, and then reopened essentially for SARS-CoV-2 infection and took care of patients initially there. And then actually watched us convert our medical ICU as well as many other intensive care units into fully isolated biocontainment units where we could keep patients safely and keep the staff safe and care for them. So it's been really incredible to watch parts of the hospital that are so familiar to you transform into totally different looking units. And it has definitely been, all in all, I think, a vertical learning curve. And that goes for the logistics of caring for patients in a biocontainment unit. Things like where do you put the mechanical ventilator so that you don't have to go in and out of the room so often just to change the oxygen? Where do you put the IV tubing so you can make sure the patients get the medications they need, but keep the nurses safe and not have to go in and out of the rooms quite so frequently? And we really had to learn how to manage those things. We had a little bit, I think, of insight and heads up in some ways because we had a couple of weeks from our colleagues in New York who had already learned some of these lessons and could give us some insight in how to manage patients in this regard. But it was really a learning curve for us here. And then, of course, the learning curve of the actual medicine of caring for COVID-19 patients. It was astounding that if you were on Facebook or Twitter, the amount of different recommendations that were coming out from some credible and many non-credible scientists that were giving guidance on how to care for COVID-19. But the truth is, at the heart of the pandemic, we really had very, very little knowledge on how to medically care for these patients, what kind of medications would work, and what was effective. So I think it was quite challenging for us to keep up with the literature, know how to care for these patients. And then, of course, we were faced with a lot of the same things we've talked about, which is having patients separated from their families and trying to learn how to manage that, keep families up to date on their patients and their loved ones' conditions, but not being able to be at the bedside with them, sitting down at the bedside with them, having a face-to-face conversation about goals of care or about their loved one's progress. So it was incredibly challenging. I will say I feel honored to have taken care of these patients and to have been kind of at the front lines, but it has certainly been a difficult couple of months.
No, I mean, just you're why they call you guys heroes. So I know you've created the post-COVID recovery care program.
Yeah.
I'd like you to talk a little bit about that. What prompted your feeling? What prompted you to do that? And what are the elements of the program? What is it exactly doing?
Yeah, so this program was actually born out of a slightly larger program, which is designed really to care for survivors of critical illness. So we know more and more that patients who get critically ill come into a medical ICU or a surgical ICU. When they recover from their critical illness, they really have multiple different complications. So they may have physical ailments from being in bed for a long time, being sick, and being deconditioned. They'll have cognitive problems like memory loss, amnesia, and then they'll have psychiatric issues. So lots will have anxiety, depression, post-traumatic stress disorder, and that's referred to as the post-ICU syndrome. So more and more we think the post-ICU syndrome is really an important thing to be thinking about and providing critical care survivors with longitudinal and convalescent care even after they leave the intensive care unit. And that really became incredibly apparent in COVID-19. We had this massive influx of critical care patients who were suffering from all those things I just mentioned, who were incredibly sick, who were in hospital beds for a long period of time, and had all of the psychiatric complications that we kind of just talked about, and PTSD because they were removed from their families, cared for by providers who were wearing spacesuits and gas masks, and really didn't have any family members to talk to through this process. So we've recognized the need for care for ICU survivors, and COVID-19 is really no different. The program is multidisciplinary, and that's really critical to success of any COVID-19 recovery clinic or really any post-ICU clinic. So at the heart of it is, of course, the patient. And the patient's physician is someone like myself, so who's a critical care, pulmonary critical care provider. But then equally important are all of the other providers who are involved in this relationship. So physical therapists, occupational therapists, psychologists, psychiatrists, if necessary. You may have palliative care involved, speech language pathology. So it's a very multidisciplinary clinic that really addresses all of the needs of people who've survived critical illness.
Wow. And so have you started to figure out, or maybe there isn't any sort of time period because everybody's such an individual, you know, what the plan is, how long you think that people are going to need to stay within the program? Are you doing, are they being trailed off and then you just keep up with them for a period of time? Or
I think it's dependent. So we've had a very large population of people here at University of Maryland Medical Center who were on ECMO or continuous bypass for COVID-19. Those patients were as sick as they come. Those patients may need longer care and they may need to be followed more regularly in the clinic. There's other patients who were less sick who maybe came in with a little bit of oxygen requirements. Otherwise, we're able to go home and quarantine at home. Those patients may need to follow up for a shorter period of time. I've actually also seen a fair number of patients who call themselves long haulers. These are patients who maybe were not critically ill, didn't even need to come into the hospital, had COVID-19 and quarantined at home, but were very, very symptomatic and remain symptomatic to the point where they're unable to return to work. They're really unable to go back to their normal activities. They can't go back to their jobs. And so these patients I see also in clinic, they may take even a longer period of time to follow up because we're really still working through exactly why they continue to be symptomatic despite the fact that their illness was quite mild to begin with.
so that leads me to a question that we've got from the audience, and that is, you know, in light of what you just said, how big is the worry about these unknown COVID-19 after effects? I mean, what are we starting to see?
Yeah. So a lot of patients complain of persistent fatigue and dyspnea. I would say more by far and away, the shortness of breath and the fatigue are the number one and two complaints. We know a little bit maybe from the Italian population. Again, they're a couple of weeks ahead of us in this process. So based on the data that came out of Italy, about 40% of patients who had COVID-19 will still have symptoms of shortness of breath and still have symptoms of fatigue, even 60 to 90 days out from their initial diagnosis. So these are real symptoms. People really are limited in their ability to return to work. You know, I think to echo some of Dr. Jarrell's points, you have to continue to wear your mask 100% of the time because you need to stay compliant with protection so that you don't end up in the hospital, and also so you don't end up with a mild case of COVID-19 that brings you into my clinic.
Wow. Scott, you have a question, Dr. Rifkin?
Sure. I want to talk a little bit about the team and the staff in the ICUs and the stress. And to tell a little personal story, my son is a MD PhD up at Columbia, and they hijacked him from his neurology residency to spend 4 months working in an ICU. And while he was there, we saw in the national papers that one of their ICU program directors, and by the way, he even talked a little bit about how there were patients in the ER that couldn't get an ICU bed. We didn't, fortunately, I think, have that in Maryland, but they ran out of vents, they ran out of ICU beds, and people passed away. And very difficult decisions had to be made. Then a program director committed suicide up in that system, if we all remember right, it was in the paper. How is the system taking care of the healthcare workers that are just under this immense stress?
Yeah, it's a good question. I think it can speak only for here at University of Maryland. We're very lucky. I think we very much took the approach that we're going to be in this as a team. We're going to take care of each other. We're going to make sure we look out for each other. If there's any evidence of burnout or moral injury, we're kind of going to tap each other out and make sure that we're taking care of each other, getting the help and resources that we need. As a program director for critical care fellows myself, I check in with my fellows all the time. I think it's important to bring them into my office, sit down at my desk in masks, of course, and just check in with them, because the burnout is real and the stress is real and the anxiety is real. And I think it's important for us to check in with each other. The hospital has offered unlimited resources really to us between employee health and psychiatric help if necessary. But I do really think for many of us, we kind of just joined arms and arm in arm and said, we will take care of each other because we had to. We made a vow to take care of the patients. This is why we went into critical care medicine. This is the kind of work that we train to do, we want to do. And along the way, we look out for each other.
Very good. Thank you.
Great question. Great to hear. We actually have another question from somebody who's watching. Dr. Levine, how do you feel? And I know Dr. Jarrell was involved in these studies, but question is there any danger in participating with these various studies? And what do you have to watch out for?
I think that's probably dependent on the study that you participate in. So I assume Dr. Jarrell got informed consent for his vaccine trial, and they told him some of the side effects that he had to watch out for. I have been trying to participate in the vaccine trial and haven't been selected myself, so I can't answer that. But we have an innumerable number of clinical trials actually running in the hospital as well, looking for the best treatment for COVID-19. So whether that's the ACT 1, 2, or 3 trial, the active trials, we trialed remdesivir. We were one of the initial sites to look at the use of remdesivir in our critically ill patients, as well as many other therapies. So for our inpatients, we have a whole slew of clinical trials that are available and a whole research team that really surveys the patients to determine which clinical trials they'd be best suited for and eligible for. As an outpatient, I guess the patients are consenting, as Dr. Jarrell did, and told of the risks of each individual medicine or vaccine that they're participating in.
So George, I'd be happy to comment on that, and it would kind of be like this, with several layers. First of all, it's called research. And when it's research, that means we don't know the outcome. That's why we're doing the study. Now, so first of all, you can't enter a trial like this expecting that the vaccine will protect you. And you can't enter a trial like this assuming that you'll be just fine, there will be no side effects. However, having said that, what I would say is, but UMB, I'm very proud to say, has a very robust institutional review board. And they comb through the data before they approve something. They make sure that the proper precautions are in place and all of those things. The third thing I would say to you, one of the reasons why I enter these clinical trials is I can't be two-faced about this. Either I believe in the process or I don't. I do believe in the process, and therefore I'm willing to participate in a trial, knowing that something could happen, but knowing that my colleagues have gone through this very, very carefully and said, we believe that the benefit here exceeds the risk.
And the scientists of this country are incredibly good at not letting the politics get involved in studies. So all that crazy stuff that goes on in politics, the IRBs and the way they set up these studies are really isolated from that. And I think the public needs to understand that.
Well, this all came from the Second World War. And I think what's very clear here is that IRBs need to function as autonomous units. They are answerable, I'd like to say, to God. They're not answerable to individuals at the university or people like that, except for one person, so-called institutional official. So they really do have the authority and the autonomy to say what they think is right And that's what carries the day. No one else can approve a protocol except the IRB.
And that's critical for confidence that once these studies are completed and once the scientific community says this is the vaccine to use because the benefits outweigh the downsides, because there's always little downsides and there's upsides. And once those are balanced by the scientists, then the public can be confident that this is the right thing to do.
Yeah.
Dr. Levine, I'd like to ask you one parting question. So we've heard from Dr. Jarrell and Dr. Peters that, you know, how they felt that we were doing as a state and a community and maintaining, we're trying to keep down the spread. Heard from Dr. Peters about what we could do to help with the post-traumatic stress disorder that can come out of this being isolated. My question for you is, how do you feel and think we're starting to do or are doing with regard to treating people with COVID? Are we starting, do we feel, or do you feel that as healthcare professionals, we're starting at least to get a baseline handle on how to treat this horrific disease?
I think for the first time, we have 2 excellent clinical trials that have been published and peer-reviewed that give us some insight on how to treat COVID-19. That is completely different than how we started this in March and April, when it was small case reports coming out of China and other countries around the globe. We were having to trust them, but they were non-peer-reviewed studies with not a lot of, I think, backbone to them. We have 2 excellent studies now suggesting that remdesivir and corticosteroids are effective in reducing mortality or improving length of hospitalization or length of ICU stay. This is tremendous. This is a huge tool in our toolbox for us as critical care doctors. These are well-executed studies. They're peer-reviewed. They're published in excellent journals. So I think for the first time, we really are in a good place. And I think it's really encouraging to see how many clinical trials are up and running. There's very, very excellent clinical trial designs that are being done at multiple institutions throughout the country, throughout the world. So I think we are making progress on actually better understanding the disease process, understanding how to treat the disease as an inpatient, getting further with our vaccine development. And I think my hope is that there will ultimately be some work done on the outpatient side too, looking at medications that may be useful in the COVID recovery period for people who have sort of longstanding lung disease or injury from their COVID-19 illness.
Thank you.
Could you repeat those 2 peer-reviewed treatments? Because everything else anybody hears is just noise out there. So please slowly repeat them so everybody hears them.
Yeah, so we have remdesivir, which was demonstrated to be effective in the ACT trial, ACTT trial, and that was published in the New England Journal of Medicine. And then we have the recovery trial, which showed that steroids, specifically dexamethasone, was effective in the treatment of COVID-19 in sick patients who require critical care, our own oxygen, mechanical ventilation. So those are now, I think, our best drugs that we have, that we feel as critical care providers, we have confidence that we know who to use them in, when to use them, what we might expect in using them. And I think we feel a little bit better about managing COVID-19 when you have 2 tools in your pocket compared to 4 months ago where you had nothing that you really knew could be effective in this virus.
And death rates, what's happening with, they're still too high, but what's happening with them?
Yeah, so they're much too high, and the number of cases is much too high, at least around the country it is. I'll say here in Maryland, the numbers are okay, and here in the University of Maryland in our hospital system, we have not seen an increase right now in the number of COVID-19 critically ill patients, so we are very fortunate for that. We know around the country the numbers are going up. So my colleagues in Denver, in Texas, Utah, they're in a very bad predicament when where their ICU beds are full. The patients are sick again and they're needing a lot of critical care. And you have to remember that in addition to COVID-19 patients needing critical care, the rest of the patients also still need the routine critical care. The surgical patients who come out of the OR and may need a little bit of ICU care, or the person who has the myocardial infarction, or the person who gets sick with influenza coming up into the season. So we are fortunate here that our ICUs are not full right now and that our numbers are manageable, but that is not what's happening in many ICUs around the country.
We have a question, Dr. Levine. Can you talk a little bit about the effectiveness of these drugs on asthmatics? You know, what complications are you seeing from that area?
Yeah, I don't think we've seen any real complications in receiving either steroids or remdesivir in asthmatics. There's no side effect profile that I'm aware of that increases your asthma exacerbation or your bronchospasm or your wheezing. We do know that people who have some degree of underlying illness, asthma, people who have diabetes, obesity, they seem to be at a little bit higher risk of getting COVID-19 and being sick from it. Although asthma in and of itself, I don't think we've identified specifically as a predisposing risk factor for COVID-19. Steroids is a commonly used treatment in asthma, and most asthma patients have been exposed to steroids at some point in their life. So certainly the steroids themselves are not of any harm to people with asthma. But the remdesivir, as far as I've seen, read, and used it myself, I have not seen any complications in patients with asthma.
Okay, thank you. Thank you. Well, I want to say thank you again to Dr. Levine, Dr. Peters, Dr. Jarrell. You guys really are, and it's been said a lot, but you guys really are on the front lines and doing what you can to help us and protect us and treat us. And for that, I can't say thank you enough on behalf of everybody here and on behalf of everybody, in the state of Maryland. It is kind of mind-boggling to most of us that we're going through this. I think it's mind-boggling, period. But I think at the same time, we're also all in our own way dealing with not only the physical health attributes of this, but the mental attributes as families, employers, employees, friends, colleagues, and the work that you all are doing and the efforts that you put into things every day is just, astounding. And I can't say thank you enough. And I can't say thank you enough for coming on this evening, because this was just absolutely wonderful. It was informative. It helped us. I know I'm walking away from this feeling like I understand a little bit better what you all are doing and how you're doing it, and how we maybe can look to be helpful in these areas. I'd be in a trial, try to identify an employee or coworker that could potentially need some additional help, or just understanding what people are going through and get the disease and what they need afterwards. So on behalf of Nemphos Braue, I think on behalf of Jmore, I want to thank you for taking the time this evening to spend with us, tell us about what's going on and what you're doing, and tell us your story. So with that, Scott, I'll turn it back over to you.
Well, thank you all for being here. And as I've mentioned before, this show went live on Facebook and will be seen over the next week or 10 days by a couple of thousand folks, and they'll get real, useful information out of it. So truly, I appreciate our sponsors at Sheppard Pratt, University of Maryland, Baltimore, University of Maryland Medical System, all for being such great sponsors of this event. Thank you for being here. Dr. Levine, if you run into my good friend, Stacy Fisher, please tell her I said hello. I'm sure you run through across and Dr. Jarrell as well. And thank you all for the unbelievable medical care we get in this community. It is a standard of care higher than in most other places in the world, most other places, even in the United States, that we get in the Baltimore area. And it's because of your institutions and the hard work you all put in. So thank you so much, and have a great evening. And again, thank you for the work you're doing.